Good evening or good afternoon if you're joining us from Western Australia today. Welcome to the APNA Adolescent Fertility and Pregnancy webinar. We're joined by our presenters tonight, which I'd like to introduce you to before we get started. We have Ruth Mercer, who's a highly experienced registered nurse. She spent almost 17 of her 25-year nursing career as a primary healthcare nurse. Ruth is an endorsed nurse practitioner and amongst many other hats works as an integral member of a multidisciplinary team within a suburban general practice in Newcastle, New South Wales. Jo Perks lives in Sydney and she is a nurse practitioner who has worked extensively in women's health services in New South Wales for over 20 years. Jo is passionate about holistic primary care and improving outcomes for her clients. She is an executive member of the Australasian Sexual Health and HIV Nurses Association and proudly an active member of the Education Committee for APNA. Thank you, Jo, for starting our presentation today.
Great, thank you very much, Lisa, and hello everyone. And I looked at the polling, the questions before, and people were talking about it being cold, so I hope that you're feeling nice and warm this evening for this webinar. So what we'd like to do is, I'll make a start and just talk about the objectives for the webinar tonight. So we're looking at both young men and young women, but we would like you to try and identify some strategies to identify at-risk young women. Just to feel a bit confident to provide information referral to young women on contraceptive choices, discuss STI testing and referrals for drug and alcohol services with their clients, be confident to provide information on pregnancy options and identify referral services. And so if you were looking at wanting to put a question in, there'll be times when if we see the questions, we'll answer as we go along, but we'll see how we progress because, you know, it might be that we answer your questions at the end of the presentation. So, I actually work at Liverpool and Penrith Women's Health Centre in Sydney, and at Liverpool I offer a young well women clinic on a Wednesday afternoon, and many of my clients are disadvantaged in some way. They're very young. I see young women from 14 to 25, so that range of adolescence, and they are a vulnerable group because the areas that I work in are quite disadvantaged. But some of the strategies you can see there on your screen, and I'll let you have a read of that. But I think it's really important to make the service youth-friendly, so that, and probably most of you do. So having, magazines like Dolly or Girlfriend sitting in your waiting room, posters, for aimed at young people, and also other information that might be in the waiting room aimed at young people. So we'll have some resources at the end for you as well. But there's a great book called Youth Health and Adolescent Medicine, and it's edited by Kang, Skinner, Sanchi and Sawyer, and they have some tips and tricks for making the service youth-friendly. So I'll just add a couple extra in. So is your practice located near public transport? Is it physically accessible for young people with a disability? Is it open after school hours and for some time on weekends? Does it offer a drop-in service as well as appointments? Are you willing to bulk bill young people? Are you willing to assist adolescent patients who don't have their own Medicare card by helping them find their Medicare number and or applying for their own card? And they can get their own card from the age of 15. Willing to prescribe generic medicines where appropriate to reduce the costs? And are you able to offer long consultations for your new adolescent patients? Does the practice have practice staff, including all reception, management and clinical staff, who can demonstrate an understanding of youth-friendly healthcare by communicating effectively with young people and assisting them in overcoming their barriers to accessing care and talking to health professionals? Have youth-friendly posters, as I've described before, and reading material in the waiting room? Does your practice have confidentiality and other relevant youth-friendly policies on display? Does the practice inquire and document as routine the adolescent's preferred methods of being contacted for test results or urgent follow-up? I do see within my clinic a lot of my young people, from a confidentiality perspective, don't want any mail to go to their home because they might be living with their parents. So we negotiate how they're going to get their results, and if it's for a chlamydia screen, for example, so they might negotiate with me to get their result by SMS or email, or they might sometimes, if I see an older adolescent who's due for a pap test, and who doesn't want an email to go home, I might actually say, well, look, let's just make it our address here at the centre. And then I would provide that timely follow-up, say for 2 years' time for a pap smear reminder. I might then email them with that reminder. So that's just one way that really works for me, and you've probably got lots of other ways that work for you. I think it's really important that we have really good resources, and we're going to try and give you some of those resources this evening. Have a list of other services in health, welfare, child protection, education and justice systems that adolescents with complex needs may be referred to, or that adolescents might contact themselves. And maybe invite some feedback and input from adolescents or their families in creating more youth-friendly initiatives. So there's just a couple of things that you probably have considered for your practice, but maybe it's also just worth thinking again. I'm going to go in now and talk about a way to actually do a psychosocial assessment on our young people. And it's called a Heads assessment. And you can see from the slides that it talks about the home environment, education, employment, eating, exercise, activities, hobbies, peer relationships, drug use, sexual activity and sexuality, suicide, depression and mental health, and safety risk. I know that we're all incredibly busy, and sometimes we are limited in our time to be able to make decent assessments, but I think it does give you a bit of an idea as to how you might sort of make a holistic assessment on a young person. It's a screening tool, so it's by no means going to give us everything, but it will give us some information about, conducting a comprehensive psychosocial assessment of the young person. And again, there's a great resource from New South Wales that can be ordered, and we have that resource at the end. It's called the Youth Health Resource Kit, which is an essential guide for workers, and that actually also goes through that Heads assessment. So with home, consider living arrangements, transients, relationships with carers, significant others, community support, supervision, any abuse, childhood experiences, cultural identity, or recent life events. Some of the questions there that you might ask, so using open-ended questions, I think are really important. So where do you live? Who lives at home with you? What is your family's cultural background? Have there been any recent changes in your family? And I would add something like, how do you get along with other members of the family? Because I know if we have adolescents ourselves, or we know of adolescents, they often really struggle to get on with others as they're growing up. For education and employment, some of the questions that might help you are about getting a sense of whether school's okay, whether they're feeling connected at school, have they experienced any bullying, what are their goals, after school? Are they wanting to go to university, for example? Have they had any changes in education or employment? Do they get along with their workmates and teachers? So you're really sort of getting a sense from me, I guess, that you're looking at those whole, that holistic assessment of adolescence. So activities, hobbies and peer relationships, and we all know how important they are. So from the screen you can see that, but there's other questions that you could ask, like who are your main friends? How do you think your friends describe you? How much TV do you watch? Do you have a smartphone or computer at home? And what do you like to do on your smartphone or computer? And I guess they'll probably think that we're prying into their personal lives a lot, but I think one of the things that I'll often ask or preempt questions is I'm going to ask you some sensitive questions about your health and what's going on in your life, and is that okay with you? So with, I'll just go to the next slide. So drug use, cigarettes and alcohol. Further questions might include, how about you? Have you tried any drugs? So open-ended questions enable us to explore further. For example, so what drugs have you tried? How do you and your friends take them? Which gives us a bit of an exploration of safety. Is there any binge drinking? We can make an assessment about that, and we'll talk more about some of these issues as we go along in the presentation. What do you and your friends do when you take drugs or drink? How do you pay for drugs and alcohol? Have you had any problems as a result of your drug and alcohol use? Do other family members take or use drugs? From sexuality perspective, you could, I've got some facts here that I'll provide for you in a moment, but some of the other questions may be, have you ever had a sexual relationship with a boy, girl, or both? What do you know about contraception if you need it and protection against sexually transmitted infections? How do you feel about relationships in general or about your own sexuality? And have you ever felt pressured or uncomfortable about sex? So a few extra facts around that. GLBTI, or gay, lesbian, bisexual, transgender and intersex young people may be at an increased risk of depression, substance use, isolation and injury due to violence. There's also an increased risk of suicide amongst GLBTI young people. In 2008, it is estimated that 138,000 young people were victims of physical or sexual assault. It's a high risk time for young people. And I found that this one was quite interesting, given that we have, a lot of unplanned pregnancies within this group. Was that a survey in 2008 of Year 10 and 12 students found that, surprisingly, 99.8% of those who reported that they had sex said they used contraception in their most recent sexual encounter. And we'll, again, as I said, we'll talk a lot more about contraception as we go. So the last one as part of the HEADS assessment is looking at suicide, self-harm, depression and mood. Additional questions around that would be, what do you do if you're feeling sad, angry or hurt? Have you lost interest in things you usually like? Do you worry about your body or your weight? So looking at, risk for eating disorders, for example. Do you ever feel very anxious, nervous or stressed? The HEADS assessment could also consider safety and spirituality as part of that whole process of history taking and getting a sense about that young person. And as I said, we do have some references around that whole thing. So that's the HEADS assessment. And what we're going to do now is you've had a polling question to find out whether you're on your own or whether you're with others. But the polling question 1 is going to come up on the screen now. So if we can have a look at that.
Okay. So hi, this is Ruth. I'm just going to pose the question. I know you can see it on the screen. So is a HEADS assessment something that you currently use, something that you might consider using in the future? And if so, something would you like some more information on? And certainly if we can provide some more information at some update regarding these facts and actually get some more information out to you regarding these types of things. So thank you for those that are actually using the assessment right now, and hopefully we'll get some stats up for you at the end.
Okay, thank you. So I'll now pass on to Ruth to look at some risk behaviours.
Okay. So in the next section, we're just going to be looking at some management of at-risk behaviours regarding contraceptive choices, and also looking about how the APNA decision support tool might be used within your own practice, looking at safe sex condoms, alcohol, tobacco and drug use, and also facilitating choice. We're really going to be exploring how nurses, primary healthcare nurses, might address issues pertaining to at-risk behaviours and how we might provide valuable information to young people, ensuring contraceptive needs are met with the individual at the centre of all of that, and also promoting safe sex, facilitating choice through knowledge and furthering empowering our young people. So looking at contraceptive choices, we're so fortunate we do have such an array in Australia of great contraceptive choices that are relatively available and relatively, not too bad in price. We're going to focus initially on long-acting reversible contraception, or LARC. Some people have heard about the term LARC. And long-acting reversible contraception, by definition, is a contraceptive device that basically has great efficacy, so increased efficacy, and less dependent on people using it. So basically, once it's in your system, whether it's an injection or an IUD or an implant, it's doing its job. And for lots of young people, this could be a significant choice of contraceptive use that maybe a lot of young people aren't aware of And even a lot of healthcare practitioners are a little bit ambivalent towards LARC because there's a fear that it's not really appropriate for young people, but that's actually not true at all. It's a really effective choice for young people. So the types of long-acting reversible contraceptive availability in Australia is the lav-unjustical IUD, or commonly known as the Mirena, the contraceptive implant, which is commonly known as the Implanon NXT. There's actually a copper IUD, and there's also an injection, which we commonly refer to as Depo. So the advantages, as we know, of these types of contraception, of the IUD, of the Mirena IUD, one of the best things about it is that once it's in, and it's actually stays in place for 5 years. There's actually going to be a new device that's hopefully going to come onto the Australian market sometime this year, hopefully, and it's slightly smaller than the present IUD, the present Mirena, and it's going to be available hopefully soon. But only available probably for 3 years, in place for 3 years. But it's certainly something that you might want to think about. It's going to be slightly smaller in use, and it might be more appropriate for younger people. But a lot of people are a little bit reluctant talking to young people about IUDs, thinking that it's not an appropriate choice for a young woman who's never had a baby. But that's not true. And it's also quite simple to put in. It has to be put in by trained health professionals. So some GP practices do it, some women's health centres do it, family planning does it with appropriately trained registered nurses and doctors. So for people that live in rural and remote communities, that could be a little bit of a disadvantage because they unfortunately may not be able to access those types of healthcare facilities, and that could be one of the disadvantages of it. But the advantages is they're able to access that type of care is the fact that once that device is in system, it can potentially stay in place for 5 years or 3 years if it's a smaller thing. The other option is the Implanon, which is the implant. And again, the effectiveness of this is something like 99.9% effective, and it also can stay in place for 3 years. So that for many people, that provides them with a cheap form of birth control. Obviously, the biggest disadvantage is that it needs to be inserted again by a trained health professional. So that could be a GP or a registered nurse who's done suitable training, or a nurse practitioner who's done suitable training. But again, for people that might live in some communities, that could be difficult to access that type of facility. But again, for those that can, it's such a great option for birth control. Again, once it's in, and it's doing its job beautifully. So there are some options there. And the other one, obviously, to consider is also the Depo shot. You've got 12 weeks, potentially 12 weeks of birth control. Of course, that one of the disadvantages is that if you don't actually like it, you can't reverse it once it's actually in your system. But after 12 weeks, that you can actually have a new injection injected. So the disadvantages for that is the fact that you do have to be able to access facilities where you can actually have a registered nurse or a doctor actually give you the Depo shot. But again, you've got to weigh up the pros and cons of all of these things. You've actually got some great forms of birth control that are long-acting. They're reversible, so they're long-acting, the fact that you don't have to rely on taking the contraceptive pill. So if people forget to take the contraceptive pill, obviously there's an increased risk of an unwanted pregnancy. I guess the disadvantages with the long-acting reversible contraception is that they don't provide any protection against STIs, and of course that's where we need to obviously significantly focus on with young people. But there's obviously measures around that where we actually can look at using a contraceptive, a hormonal contraceptive form, but also doubling that up and using a barrier method too, such as condoms. Okay, so the other...
add in, Ruth, sorry, I do quite a lot of Implanon insertions, and I think I'm slowly starting to get more young women interested, but they do balk at you know, having something in their arm and having, you know, the local anaesthetic. But once, you know, and also I think they do hear a lot of stories about bleeding problems on Implanon. But I think the key to having, you know, a success with Implanon is talking and a lot of counselling around bleeding and, you know, support, you know, both prior and during the time of the rod.
And I think that goes also for the Mirena IUD too. Absolutely. So. Yep. You know, I've actually dealt with women who've had it put in different facilities, and they come back and, you know, 6 weeks, they come back and they say, they come and they check and they say, I just want this thing removed. And yep. It's like, why do you want it removed? I want it removed because I'm spotting, and it must mean there's something wrong with it. Well, realistically, the best thing with that is that if you actually pre-educate people before they choose and they're fully aware of the pros and cons of any birth control, they actually learn to live with it. If they know they're going to get a little bit of irregular bleeding, whether it's the hormone implant or the IUD, they can cope with that. But it's not fair to actually, and it's wrong to be thinking about, you know, suggesting a form of birth control without actually giving them all of the facts, so that they're actually, they're frightened thinking that they're actually going to have an unwanted pregnancy, or that there's something wrong because they're spotting. So that's a really good point to make to people. And I guess the point that we also want to make in all of this is the fact that for many nurses that work in primary healthcare, this may not be your focus. This may not be something that you do day to day. But what we're saying to is having that knowledge is, and engaging with young people, is that when you meet them, you may not know all the facts, but you know something, and you might say, look, I might not be the right person to address this with you, but actually one of my colleagues is, or, you know, you might be best suited to go into family planning or to a women's health centre or wherever to meet these particular needs, but actually getting some facts on board, and that you're actually, you know, giving some knowledgeable education to our young people.
Yep.
So we're going to look at other forms of hormonal contraceptive methods. So obviously the pill, which is, you know, a great form of birth control. Progesterone-only pill, which is an option for women who have contraindications to using the combined pill. And for lots of young women that I see, they think that it's just the pill that you just have when you've had a baby and you're breastfeeding, and that's a myth that we need to sort of dispel. So for lots of people, that the progesterone-only pill is a good form of birth control, and it can, once it's used effectively, and people are aware of how it needs to be taken, it needs to be regularly taken at the same time, it can be used effectively, and it's not just for women who are breastfeeding or just had a baby. And obviously the combined oral contraceptive pill, it's been around for a long time. It's safe. Obviously, it needs to be prescribed by an appropriately trained person who's able to do that. But again, we're saying to lots of nurses that work in primary healthcare settings is actually to have that knowledge, so that you might have a conversation with that young person about why they're on the pill. And it's interesting to see that, important to remember that the pill is not only just for birth control, that many may be actually prescribed a pill to control their periods and to reduce menstrual pain, and also to help alleviate acne. Therefore, during a consultation with young women, look at their medication and ask them, I see that you're on the pill, why are you prescribed the pill? Is it for birth control, or is it for another reason? And for lots of people, they may have never really, they may be taking it for, for acne or whatever else, or to control their periods. And they then they engage in a sexual relationship, and they're just thinking the pill's going to stop them from an unwanted pregnancy. But do they really understand the implications of actually safe sex? And are they aware that they have no protection against STIs? So again, we're not presuming that everybody that's on the pill is using for that particular reason. They may be using it for other reasons, and it's an important question to ask. The other thing that we want to say too is just to be available, to be aware of the availability of emergency contraception, that this is something that in Australia we're able to actually buy over the counter at the pharmacist, and to speak to the pharmacist about this. I mean, it can be prescribed on prescription, both by GPs and nurse practitioners are able to prescribe it, but also for people who don't have access or would just prefer to go to the chemist, they actually are able to actually buy it over the counter following a consultation with a pharmacist. So that's an important message that we need to get out there. And it's also not a form of birth control that's just the morning after pill, as we know that this type of contraception, emergency contraception, can be used for some time after unprotected sex, and it's an important message to get out there. Obviously, it's most effective when used within the first 24 hours of unprotected sex, but it can be used for some time afterwards, and that's a message we need to get out there too. Okay. So going back to barrier methods of contraception, obviously this is a great form of contraception, but it takes quite a little bit of reliability. You need to be actually putting on the condom to actually have protected sex. And we're also, as we mentioned before, we talked about using, advocating the double Dutch approach to contraception, which is the best protection against pregnancy and sexually transmissible infections for sexually active people. And also to be aware that there are actually female condoms available. You can buy them from women's health centres, some women's health centres, family planning, and some pharmacists do sell them as well. And it is a really good option for some women I think that takes a little bit of user-friendliness with them. It probably takes a bit of practice with how to use them, but it's also something that we need to be letting down, that women actually can make that choice themselves, and they can actually have some extra protection themselves. They don't have to rely on someone with condoms, so on male condoms. And I think Jo wants to talk a little bit about some barrier methods that are available in Australia. There's been some recent changes.
Yeah, thanks, Ruth. So I'm not sure whether, people have heard of a new diaphragm called CAYA, which is C-A-Y-A. It's available from medical industries, and it will actually replace the conventional diaphragm that's been around for quite a few years by the end of the year. So it's a one-size-fits-all, and it does require a tube of, it's a little bit like spermicide that goes with it. So it's quite expensive, and possibly it is cost prohibitive for young women, but I know that there is a group of young women who do like to use the barriers, as Ruth has discussed, but also to use the diaphragms, because a lot of the hormones, or a lot of the contraception, as we've heard, are hormone based, and there is a group of women who don't want to use hormones, so for them a diaphragm might be suitable. So CAYA, it's as I said, available from medical industries. If you look up their website, then you'll be able to get more information, and they are in the process of sending out trial sizes or the trials for fitting, and they'll also send you some information about how to sterilise them so that you can reuse them. So thanks for that, Ruth.
Okay. All right. We're just going to move on and just looking at the recognition of potential fertility issues for young women. We're also going to look at fertility issues for men. So this might not be something that a lot of people would think, well, why are you going to have this conversation with a young person? But it's really important to bring these conversations up early in the piece, because there might be things that you might suggest or recommend to young people that sort of sticks in their mind, and then really gets them thinking about what are they doing in their life now that has the potential to negatively affect their ability to have children later on down the path. And we know from statistics that this is actually something that young people do actually think about. It's not something that people are interested in this, and it's an important component of what we as primary healthcare nurses need to be promoting to our young people, that whatever we do now has the potential to affect our fertility. So things like general health and the impact of chronic diseases on fertility, things like for women, PCOS and endometriosis. A lot of women may not realise that, PCOS is quite common, and if picked up early, then fertility issues can be managed. Hang on, I'll just flick back. Can be managed appropriately. For women with endometriosis, their fertility is perhaps something that they're not really aware of at this stage of their life. Perhaps their concerns are more associated with pain or bleeding. And for women with chronic diseases such as diabetes and epilepsy, are they aware that their future fertility or potential pregnancies may need a little extra pre-planning and considerations due to the potential effect of their medications, for example? They're the types of things that many young people may not think about, but obviously it would be quite detrimental for a young person who's perhaps taking some medication that's potentially teratogenic, such as some epileptic medication, and realise that if they're not potentially looking at their contraceptive needs effectively, that they may have an unplanned pregnancy with some significant negative consequences for that baby. And also, what about weight? Are your young women aware that being overweight or underweight has a potential negative effect on their fertility? It's a huge component, and it may be something that may actually get them thinking about. It may be the push to think about getting into a healthy weight range, the fact that if that's going to affect their fertility and later on in life, it may be a reason to either lose weight if they need to lose weight, or gain weight if they're in a really underweight weight category. So that's something that we need to be raising with our young people. And also the risk of STIs. What STIs are there that potentially have the impact or negative impact on future fertility? We'll touch on that later in the talk. I think Jo's going to talk a little bit more about that. But realistically, things like chlamydia is a classic one. So for women and men who contract chlamydia, their potential fertility, if untreated, is quite significant, and that's something that we could do something about that quite easily by making sure that young men and women are aware that there are STIs out there that can affect their long-term health and their fertility long-term. So for our young men, it's a similar type of thing, weight management. A lot of young men may be overweight, and that has a significant effect on their fertility long term. Also, the impact of drugs and alcohol. Just particularly wanted to talk about going on to something that a lot of young men may be using. It's things like, well, not necessarily young men, there's also young women may be using it too, but using steroids for bodybuilding and the impact on their fertility. So anabolic steroids are drugs that are derived from testosterone, which is a male hormone, and some are in tablet form and others are actually injected. Some may take anabolic steroids because they believe that their steroids increase lean muscle mass and strength and endurance. But scientific studies have only shown that anabolic steroids enhance physical performance through the effective training, diet, and motivation which accompany the use of these drugs. And the side effects of anabolic steroids include baldness, acne, jaundice, heart problems, arrhythmias, high blood pressure, fluid retention, heart attacks, development of breast tissue, and also infertility, and also diabetes. So there's some significant impacts on their health that, again, if we actually have those questions, if we, through the questionings or the assessment that Joe was talking about, the HEADS assessment, this might be something that's raised in that assessment, and it's something that you actually might bring to the fore to your young people to say, do you realize the long-term implications of what you're actually doing to your body, and how it could negatively impact your ability to father a child if that's what you choose to do so. And also smoking. Heavy smokers produce fewer sperm, male obviously, and have increased numbers of abnormally shaped sperm. And there's also evidence that some chemicals in the tobacco can damage the sperm DNA, potentially affecting the health of a conceived fetus. So that's a pretty significant things to think about. So again, you might be thinking, why are we asking these questions of our young people? But if you're seeing young people, it's an opportunity to raise the issues of their health, their lifestyle, just like we would with smoking cessation. We have conversations with young people, or conversations with many of our patients regarding smoking cessation for all of their long-term health issues. But fertility is the other issue that has a negative impact.
Hey Ruth, before we go to the next slide, there's a couple of questions that have come into our inbox.
Okay.
Are you happy for me to read them out?
Yep.
Yeah. So we'll answer a couple of questions before we go to the next polling question. So from Julianne B, how long do you recommend these women need to wait before they reject Implanon, for instance? And again, I think I'd just probably reiterate what Ruth talked about was around that whole counselling aspect. And when I'm talking to women prior to having their Implanon inserted, I would often say, I can't predict your bleeding pattern, but I know that some women will have no periods, some will have regular periods, and some will have nuisance bleeding. And I usually try and get them to persevere for at least 6 months, but I also will get them to come back and see me if they need to. And one of the good successes that I've had is actually, if the young person is suitable, I've actually given her 4 months of a low-dose oral contraceptive pill, and she just takes the hormone pills for that 4 months, not the sugar pills, and that seems to really help with her bleeding, and then she can keep persevering with it. But most women, unless the bleeding's really, problematic for them, will persevere, and I'm going to do some research this year around looking at, the numbers of women who've persevered to that 3-year mark, and I've had women who've had their 5th rod with really no dramas. The next one is from Janet. Is the vaginal ring popular? Well, the vaginal ring is the pill in the vagina, as most of you know, which is a release of hormone over 3 weeks, and it sits in the vagina, and then you take it out and you have a withdrawal bleed. Look, I think the problem with the vaginal ring is A, it's expensive, so it's quite a lot of money to afford for most young people. Having said that, most women, full stop. But I also think that lots of women don't like putting things into their vagina. There are young women who don't use tampons; they're only using pads. So I think there needs to be a really good assessment as to whether that might be suitable. So when you're looking at your contraceptive counselling, you'd probably ask sort of questions like that. And then I'll just go with a last one, is our pharmacy won't give out emergency contraception, I think, if under 16. And I guess that would bring up the issue around mature minors and reporting of underage sexual activity. And I think that the pharmacists probably have their own code of ethics there. But that's really hard if there's only the one pharmacy in the town, and that might be where Ruth, you talked about getting a prescription for emergency contraception from GP or nurse practitioner, which is just really a lot of progesterone-only pill, but it will do the same thing. So we'll move on, Ruth, or do you want to answer any of those other questions?
No, I just thank you for Cheryl made the point that that also for males the risk of bloodborne viruses when sharing injecting equipment, and they don't believe that when injecting steroids it has the same risk of a bloodborne virus as an injecting drug user. So I think that's a really good point to make. They probably see themselves to be in quite a different category from an IV drug user, but yet their risk of bloodborne viruses are just the same. And that can be something that can probably be quite confronting to hear, but obviously the truth needs to be said. And I think that's a really good point, Cheryl, for making that. So thank you.
Yep. And then just do many women use female condoms? I think that there are a cohort, I don't have any stats around that, Janet, but I think that there are a cohort of women who do use them. But I know that when I show them to young people, they sort of look at me and laugh and ask me if I'm serious. I have tried them out. I sort of tend to be a person who likes to try things out before I can provide information to my clients. And I guess they're fine, they're a bit messy, and they make a noise. But then what I usually say to my clients is, well, sex makes a noise anyway. And if that's how I think the good thing about female condoms is, from a negotiation perspective, I think sometimes it's really hard to get men and boys to use condoms, and so the female condom is an option there.
I also think that's a really good point that Jo's made too about the whole thing about the way things are potentially sold, about the way we speak and the way the choice of words that we have. Yeah. I've had conversations with young women about diaphragms, and it's like, it can actually be quite an effective form of birth control if used appropriately. And for lots of women, it actually gives them a really good option to use, because obviously a lot of young people don't necessarily want the whole hormone thing happening, and it gives them some control. And it's the way you sell it. So, it doesn't have to be, you've got to pop it in just as everything is sort of heating up if you're having sex. If you think about it, it's like when you pop, you clean your teeth and you go to the toilet and you pop your diaphragm in. It's the way we're actually selling it that can make a big difference. And like Joseph said, the female condom, I suspect more people would use it if more people knew more about it and actually sort of positively sold it rather than negatively selling it. So I think that's a really good point.
That is a good point. So we'll move to the next slide, which is another polling question. And it's just about, have you ever encouraged the use of both a hormonal contraceptive and condom in the added protection against an unplanned pregnancy and STIs? Wow. So that's looking pretty good. Okay, so it looks like we might have...
very impressive.
Yes, absolutely. Exhausted the poll. And we'll go on to our next slide. Okay, so I'm back again. It's Jo back again. I'm going to start to talk now about some STI testing and drug and alcohol referrals. And I was fortunate enough to be able to participate in the first dot point on this slide, which is the Australian STI guidelines for use in primary care. It's great if you can have it on your favourites on your computer. It's got all of the most up-to-date current treatment options for all of the STIs that we know about. And, the different groups of people, like women who have sex with women or men who have sex with men, young heterosexuals. It looks at what testing we need to be doing. So it's a fantastic resource, and I'd really say, have a good look at it. It's wonderful. The links to alcohol, tobacco and other drug services, we'll provide those with the links. The links will go out with the recording for you. And most of you would know about a service called Headspace, which provides pretty comprehensive mental health assessments probably using lots of the HEADS assessment there, counselling, support for young people, and there are a lot of Headspaces that are being set up across Australia now. So they're useful services and resources to have in mind. And this is just giving a little bit of a cartoon which sort of talks about, some of the main STIs, and we don't, for the purpose of the presentation, we don't really have time to go into all of them. But I think it's good to know, and I know that at family planning you can buy little toys that, represent different, STIs, so that you can, like, they're little puppets that you can show to your young people if that's, what you're doing some health promotion around. So the term sexually transmitted infection is used to describe infections which are solely or commonly spread through sexual contact. Many STIs are asymptomatic in their infectious stages, which increases the likelihood of the onward spreading of the infection. And there is a public health approach to the management of STIs. Where are we? Okay. So we're going to show you a YouTube clip shortly, but from the slide here you can see that a comprehensive approach includes access to clinical care. So looking at, what your resources are. So for example, youth health clinic, GP, women's health centre, sexual health clinics, all of those sorts of areas where testing occurs. Health promotion and ongoing education, and in New South Wales we usually have attached to the public health units sexual health clinics and health promotion around STIs and including HIV. Screening and testing and the contact tracing, so there'll be information there and links to contact tracing. So it's all really important to be able to utilise all of those points, because it just has a knock-on effect. For example, if you have a young person with chlamydia and their contact partners haven't been traced, so it's a bit like, the herd passing on the chlamydia with every act of unprotected sex. So maybe we can have a short look at the YouTube clip. Thank you.
I had a really lovely night.
Yeah, me too.
Bye.
See you later.
Thanks for last night.
You were great last night.
Hey, when am I going to see you again?
When it comes to sexually transmissible infections, sleeping with one person is sleeping with many, so get tested for STIs and play safe. Authorised by the New South Wales Government, Sydney.
Okay, so that's available. I find that YouTubes are wonderful for finding different information, even to show for health promotion as well to our clients. Okay, so the websites will be sent with the link to the webinar recording, and this is where we as primary healthcare nurses play a significant role and have the potential to make a significant impact in disease prevention and health promotion. Access to clinical care and affordability, so find or be aware of services in your area that offer bulk billing or free services. So I've talked a little bit about that. So family planning, sexual health, women's health, community nurse practitioners in women's health nurses. Health promotion and education may be opportunistic, and we need to identify those at risk. So hence that's why we sort of talked about the HEADS assessment at the beginning. So looking at safe sex, condom use, if it's not on, etc. Screening or testing asymptomatic individuals for infection is an important tool in the control of STIs, as many STIs are asymptomatic. So screening can be undertaken on an opportunistic basis, and check out the STI public, I can't remember the acronym now, STIPU, STI testing tool. Can you help me with that one, Ruth?
Yeah, no, the STIPU one, yeah.
STIPU, yeah.
Yeah.
Yep. Screening may be as simple as collecting a urine specimen of having a female patient do a self-collected swab. It's quick, simple and payable under Medicare under screening. And contact tracing, partner notification involves alerting all sexual contacts of an individual diagnosed with an STI to the fact that they may have been exposed. Its primary objective is to interrupt the transmission of STI. And there is available also the Australasian Contact Tracing Manual and the STI Contact Tracing Tool for GPs. And that's coming up on that slide there. So this information has been added to the resource documents, which APNA will send along with a link to the recording of the webinar in the coming week. The message here is that there are many places to get invaluable resources from, professional resources and resources you might share with patients. You probably all have your decision support tool in front of you with a bit of luck. If you haven't got one, let us know and we'll get one out to you. It might be a good place to look at. Then why not start a collection of your favourites and have them on your desktop for easy access or on your practice's intranet if available. Okay, so we'll go to the next slide.
Can I just add something, Jo?
Yes, absolutely.
Regarding, we talked about contact tracing, but regarding immunisations, I think there's a really good point with, particularly with blood-borne viruses and about what we could immunise against, particularly hepatitis B I'm thinking about. I've got teenage children, and I remember my kids coming home with the request to have immunisations done at school through the school nurses, and it could be quite confusing to some people because obviously the hepatitis B immunisation was introduced in the schedule for 2000, and then we did that catch-up campaign. But obviously we're going to have kids who are sort of 16, 17 and 18 who obviously may get actually the hepatitis B shots through school, but the kids older than that who may have left school before that catch-up was actually given out or decided not to have it may not have protection against hepatitis B. And I think that's a question that we need to be making sure that at-risk people are protected, and it's obviously as simple as giving them education, but also protecting them with immunisations for disease-preventable vaccines. So that's a really important message to get out there, is really ask your young people, and if they've not had it, then really encourage them to be immunised against what they can be immunised, particularly, like I said, the hepatitis B and also the hepatitis A, and also the human papillomavirus. Obviously, sometimes those people are going to have to pay for it if they're older, but again, what's the cost of that against protecting what you can protect against? So just remember that one with your young people too.
Absolutely, and part of it, the STI screening on the new guidelines for young people is talking about offering chlamydia screening and hepatitis B, you know, and screening for Hep B, and that might be all you need to do once you've done an assessment around the risk for STIs. But there are numerous STIs, as we've shown, but for today's presentation we might take a snapshot of chlamydia. So why chlamydia? Well, chlamydia is the most common bacterial sexually transmitted infection in Australia. Notification rates for this notifiable disease have increased over the years. In 2011, there were more than 80,000 chlamydia infections reported in Australia at a rate of 362 new cases per 100,000. These results indicate a staggering 21,800 more cases than the average of the previous 5 years. And that's an interesting one around whether we're screening more or whether there's more chlamydia, you know, out there. It's a sort of a bit of a chicken and an egg question, really. But the rates of chlamydia detected in females was 422 per 100,000 and 300 per 100,000 in males. So for both sexes, and this is where our adolescents come in, rates were highest in those aged 15 to 24. And we are actually also now offering screening up to 29 routinely from new guidelines, and anyone who we're looking at offering screening annually or with a change of sexual partner. And just it comes into a conversation around, you know, it might come into a conversation around travel medicine or, you know, a routine pap test, for example, or even a routine pill prescription or other, you know, information about other contraception. So for me, like what we've been talking, I think that it all weaves in, and you can get a sense from that. In 2011, chlamydia was the most frequently reported notifiable condition in Australia, with 79,833 new notifications for persons aged 15 and over, or 435 cases per 100,000 population. This was nearly 7 times the rate of the next most frequently reported notifiable STI, which is gonorrhea. This rate has more than tripled over the past decade, increasing from 130 notifications per 100,000 in 2001. Pretty amazing. The prevalence in some population groups in Australia has been found to be much higher. So Aboriginal and Torres Strait Islander men and women, female sex workers, men who have sex with men, and young heterosexual men and women. The information I gave you at the beginning of the presentation, which talked about 99.8% using contraception, didn't really talk about whether sex was safe. So there may have been some contraception there, but not necessarily, you know, a condom as well. So I think that polling question, and it sounds like you're all really, you know, up on that one around, you know, using condoms as well as other contraceptives. And surveys of Australian secondary students have been carried out approximately every 2 years. And you can Google the Australian schools secondary students, and I think it's an organisation in Melbourne who does that survey every 2 years, and that gives you a lot of information about the age that young people are having sex, the risk for STIs, contraceptive use, all of that sort of thing. So it's quite an interesting website and reports to have a look at. So I'll let Ruth take over again.
Okay, thanks. And some people, thank you, are sharing some really good resources. So we're going to collate all those resources that people are also submitting and also share them with everybody else. So thank you for your contributions. And if anybody else wants to add anything, please do so, because we can all learn from all of this. Yeah, so we're just going to focus on a little bit about alcohol, tobacco, and other drugs. So just some stats that alcohol is the most widely used drug in Australia. And 86.2% of Australians aged 14 years and over have drunk alcohol one or more times in their lives. 37.3% of Australians aged 14 and over consume alcohol on a weekly basis. It's quite a staggering statistic, I think. And young Australians aged 14 to 24 have had their first full serve of alcohol by the age of 15.7 years on average. And that's statistics from Australian Health and Welfare just last year, so 2014. 17% of, this is some statistics that was taken from that secondary student sexual health research. So 17% of 15 to 18-year-olds have had sex whilst drunk, which they later regretted. Friends or acquaintances are more likely the source of alcohol for the 12 to 17-year-olds, and parents being the second most likely source. Again, this is taken from Australia Health and Welfare 2014. And alcohol contributes to 3 major causes of teen deaths, which is injury, homicide, and suicide, which is quite a scary statistic as well. So alcohol is the leading consumption, is the second leading cause of preventable diseases, morbidity, and mortality. And the social costs are expected to exceed $15 billion per annum. So we want to look at the use of alcohol, and it's how scary it is, and the potential for the morbidity and increased risk factors for lots of things. The NHMRC guidelines, there's some recent guidelines released talking about the key message in relation to young people. And Guideline 3 looks at children and young people under 18 years of age. And the recommendation is that for children and young people under the age of 18, not drinking alcohol is the safest option. And parents and caregivers should be advised that children under the age of 15 are at the greatest risk of harm from drinking, and that for this age group, not drinking alcohol is especially important. And for children aged 15 to 17 years, the safest option is to delay the initiation of drinking for as long as possible. Binge drinking is obviously a significant thing, and reducing the risk of injury on a single occasion of drinking is part of the guideline number 2, and that's particularly important for as the fact that alcohol impairs judgment, and teenagers are more likely to engage in unsafe sexual practices when they have been drinking. And other associated risks include date rape, sexual intercourse without a condom, exposure to sexually transmissible infections, and possible pregnancy. So I guess it just takes away some inhibitions, and it puts people in danger potentially, and they may then go on to do something that they later regret, and obviously have some significant health indications of having unprotected sex, and also being left with a potentially unwanted pregnancy as well. So something to seriously think about. Results from the National Drug Strategy, this was in 2013, indicate that 72.3% of young people are choosing not to drink, but 8.7% of them had more than 4 standard drinks at least once a month, and around 1 in 6 had tried cannabis, and 94% had never smoked, and just under 3.7% smoked on a daily basis. So alcohol, cannabis and tobacco are the 3 most commonly used drugs by young people. Results from the Australian secondary students in 2011 indicate that nearly 3% had tried amphetamines, 2.7% had tried ecstasy, and around 1 in 5 12 to 17-year-olds have deliberately sniffed inhalants at least once, such as petrol, glue and solvents. And the drugs, 1.7%, it's only a small number but still scary, of 12 to 17-year-olds who take cocaine have used it once or twice, and 1.6% of kids have actually tried heroin. There's, again, some really good resources, and there's a plethora of resources out there. And again, we've just put a few on the screen for you to look at, but we're going to send some extra links out there too. There's also a really good link we're going to look at in a few minutes, and it's talking about what a standard drink is and how much people think is an appropriate number of drinks. I tried to find out, we actually use a really good tool within the general practice that I work at. You can't get them anymore because I tried to see if I could order some, but it's actually a standard drink cup that actually has measurements, and it shows you how much, the measure of a white wine or a standard midi or whatever. And it's actually a really good tool to use when showing patients actually how much a drink is. And I know that, the wine glasses that we have at our house is like a small bucket. And when you think about how much wine you put in that glass, if you actually will fill it up to the line that you do when you go to a restaurant or something, which is actually the standard drink, it's probably the wine that sometimes is poured in your own home is probably twice as much. And you're thinking about young people or anybody drinking alcohol, they think they might confess to having 1 or 2 wines a night or something, but realistically, is 1 or 2 wines a night actually what they're drinking, or are they actually drinking potentially double that? And that's something, again, that we need to be having that conversation with all our patients, not just our young people, particularly related to the comorbidities associated with long-term alcohol use, and also obviously the impeding negative aspects of also on fertility. So now we might just share with you, if that's all right, Laura, a small video. It goes for about 3.5 minutes.
This is Ben. He's an average Australian. He likes having a beer while watching the footy. He enjoys a few at a barbecue. He and his mates save money by drinking before they go out.
Ben is no exception. Australia is a country of drinkers, and for most of us, alcohol doesn't seem a big problem. But a study by Turning Point released in March suggests that we don't have a clue when it comes to identifying safe drinking levels. 95% of the population don't know how much is too much. So, we thought we'd test this knowledge on the streets. How many drinks do you think is the limit for low-risk drinking?
It's 4, I think. Is it?
4 to 6 standard drinks.
Or maybe 6? Probably around 5. Maybe like 5 or 6. 5.
As you can see, perceptions are varied. So, rather than talking numbers, I'm going to show you what people think. This is how much the average 14 to 19-year-old girl thinks is safe to drink in a single session. What about guys the same age? Well, they think that it's safe to drink this much in a single session. So, that's the perception. What's the reality? Well, while they don't drink this much every day, nearly half of that same group admit to drinking at least this much in a single sitting. Compare that to this, which is what's actually okay per day, and this, which is what's okay on occasion. We thought we'd ask someone to give us a little bit more information about low-risk drinking levels and what excessive drinking is doing to us now. So we came to Turning Point, Alcohol and Drug Centre, to talk to Professor Dan Lubman. Dan, thanks for talking to us. I'd just like to ask you a few questions about alcohol. The long-term effects of alcohol are relatively well known, but what are the real short-term dangers that we should be worrying about?
Yeah, I mean, I think particularly for young people, you know, it's the short-term harms that are the most significant related to alcohol. Alcohol basically shuts down the front part of the brain, the part of the brain that's involved in thinking, in terms of judgment and planning. As the concentration of alcohol rises in our blood, we make much more risky, impulsive decisions. And so the harms most typically associated with drinking too much in a single occasion, getting involved in a fight, doing some crazy stuff which leads to injuries, getting into a car, you know, either to drive or with somebody else who's been drinking too much. We know that half of all alcohol-related injuries on the roads, you know, related to young people under the age of 25. And the final thing is particularly for women, you know, if you drink too much more likely to put yourself in a compromising position, much more likely to be sexually assaulted, you know, when you've had too much on board. I think the key message I'll put across is that, you know, we live in a culture where alcohol, you know, drinking heavily is normalised and people get into trouble, people get into harm, so we see that all the time. I think it's important that people recognise that and we think about together how we make sure we keep each other safe.
So, what do we know? Well, we know from Dan that excessive drinking poses real immediate dangers. We know that a lot of people don't know how much is safe to drink, and we know that many of us have gone beyond the limit. So, next time you're out on the town, know your limits, make a plan, and take care of your mates.
Okay, I hope you enjoyed that. It was actually quite confronting when you see that, to see actually how many drinks some young people thought that was actually acceptable. The DrinkWise logo on the screen is actually a really good resource, and they've got some particularly great resources that are directed at young people under the age of 18. So I'd encourage you to have a look at those resources, and maybe that's the type of clip that you might actually want to show your patients too sometime. It might be a good, a bit of a learning curve for some of those young people to actually watch that and see what a lot of young people are thinking regarding what's appropriate to drink. Also related to tobacco, there's some really good resources out there on assisting people to actually stop smoking, and also in drug use as well. So research from 2013, the National Drug Strategy, indicated that about 12.8%, about 2.5 million people in Australia smoke daily, and more males than females smoke, related possibly about 14.5 to 11.2% respectively. So some good statistics there, and we also know that smoking rates in Australia adults have declined steadily since the 1970s, and since 1991 the proportion of daily smokers was almost halved from 24.3% to 12.8% respectively. So the message is getting out there, but we've still got a long way to go. But I think if we can keep chipping away at that by again, raising these conversations with all our patients and obviously all our young people to really bring this to the fore and to keep bringing it up. And you know, smoking cessation is what a lot of us do a lot of, but we need just to keep encouraging and having those conversations open with our patients.
Ruth, before we go to the polling question 3, there are a couple of other questions.
Yeah, I saw one from Julianne B. made a really good comment about still struggling with couples where only one partner actively seeks treatment for chlamydia. So just to let you know, and we will put this up, there's a really good resource. It's called Let Them Know, and it can be an online, an anonymous system where you can actually let partners know or ex-partners know if you've actually been detected with a sexually transmissible infection such as chlamydia. It's a really good tool to show young people, and it's also a really good resource to reassure them. So if actually someone's had a diagnosis of chlamydia, and realistically that whole thing with contact tracing is that you actually want them to, we want to try and stop that spread by contact tracing. That anonymous type of system where basically they'd get an SMS and it just sort of says that you may have been exposed to something. It's a good idea to go and see your sexual health physician or a nurse at the clinic or wherever, and to actually get some treatment. So that's something that we need to be getting that message out there, because obviously if one person is treated for chlamydia, but then the people that they've actually been sexually active with aren't, not actually stopping it, and we need to be doing that by getting that message out there. So thanks for bringing that really good point up.
Exactly, and I can add to that. I've been working with a young woman who I think is now 19, who keeps being reinfected, and I think that a lot of her issues are around her body image and self-esteem, and actually negotiating that, use of condoms with her male partners. And so sometimes, you do have to do some extra work with young people around, improving how they might improve their self-esteem, how they might improve how they feel about themselves. And again, that relates to, the Heads assessment and just having a bit of awareness about what else might be going on in their lives. I'll just answer the one from Joan around continuing with Implanon before having a break. I guess with Implanon, there's really no delay in return of fertility. So if someone's wanting, doesn't want to have an unplanned pregnancy, then we would probably encourage removal and insert within that 3-year, time frame, so that it's not gone over the 3 years. But I guess it's also a good time to talk about preconception and looking after ourselves when we've got some contraception on board, so we can have some tests done and get into good health for pregnancy. But I think I did also allude to the fact that I have a couple of clients who have had, their 4th and 5th rods in, and they're really happy with them. I put one in today. She's not a young person, but I think in theory she is. She's 51, so we're concerned about her fertility still, but it's still fine at that end of life as well. So that's always a good thing. So we'll put up the next slide, which is a polling question. And I think Ruth's points about illicit drugs, smoking, alcohol are really good, but it's just looking at, do you routinely question your young adult patients regarding their daily, weekly, monthly alcohol consumption? And do you routinely ask your young adult patients regarding their use of illicit drugs? Okay. So it looks like there's a group that probably have got quite a lot of information from that aspect of the webinar and are able to, maybe develop some resources and tools for, how they might talk to their young patients about, drugs and alcohol. So that's really good. Okay, so I'm going to move on and talk about pregnancy now, and we're getting there with our webinar, so it's gone really fast. You can see that around half of all pregnancies in Australia are unplanned, and in 2010 there were over 11,000 births to teenage mothers in Australia, which equates to about 3.8% of total births. So remember that teenage pregnancies are not always unplanned. Some teenagers plan to become pregnant or choose to not use contraception despite knowing that a pregnancy is a possibility. And I would probably add in there that a lot of women, young women, older women, don't have a lot or haven't been educated around how their menstrual cycle works. And I know that probably you do the same, Ruth, spend a lot of time talking to both young people and older women about the menstrual cycle and ovulation and fertility, and just getting them to have a sense of understanding around that. So some of the major reasons for unplanned pregnancies include the use of alcohol or drugs and the inability to make an informed choice regarding having or not having sex, contraception not being used or contraception failure, such as forgetting to take the pill or a condom break. And we know that condoms can break, and that there's an opportunity there to say, encourage people to use lubricant as well when they're using condoms. Poor understanding regarding the form of contraception used and a lack of understanding regarding fertility, which we talked about. Not being able to access contraception through geographical isolation, embarrassment in asking for it, or cost, for example. And we have looked at that rural and remote, and even sometimes in the cities it's very difficult to access contraception. And an inability to acknowledge that a pregnancy could happen to them, and a sexual assault. So unplanned pregnancy, where to next? So there's some resources that have come up on the slide there, and I might just talk to some of them. So Know for Sure has been developed by an organisation called Children by Choice, which is based in Queensland. And that's actually, I had a look at that this afternoon, and it's a great website for young people, and it talks about options and myths about pregnancy and, you know, particularly sort of options that are available for women, and provides some contacts as well. The Pregnancy, Birth and Baby website has information, and it's also has a 1-800 number that can provide information, support and referrals around all aspects of pregnancy, birth and parenting. And that's a really good site, and that's Australia-wide. And then Sexual Health and Family Planning Australia, that's the peak body for most of the family planning clinics within Australia. And they are a great website as well, and they've got information and booklets around unplanned pregnancy, contraception and other resources, and they also do mail order. So if you get an opportunity, if you haven't done, check out some of the family planning services within your state or even federally. Our other resources could be our GPs, our primary healthcare nurses, nurse practitioners working in women's health, nurses working in family planning. So in New South Wales, Family Planning New South Wales has what's called a talk line, which is staffed by nurses 5 days a week who answer questions and provide information referral about pregnancy and also, you know, sexual and reproductive health issues per se. So pregnancy support counselling is also available, and any sort of counselling around pregnancy should be non-directive. So, you know, looking at not sort of telling the young woman what she needs to do, it's actually facilitating a choice with her. There are some rebates that come in under Medicare to a person who's currently pregnant or has been pregnant in the preceding 12 months. Rebates are available for up to 3 non-directive pregnancy support counselling services per patient per pregnancy. A person who is currently pregnant or has been pregnant in the preceding 12 months may access the service. Services can address all pregnancy-related issues for which non-directive counselling is appropriate. And services are provided by eligible GPs and allied health professionals on referral from the GP. So this might be to an eligible psychologist, a social worker or a mental health nurse. And certainly the Australian College of Mental Health Nurses does provide training for nurses around pregnancy and all pregnancy options. Okay, go on. So information on pregnancy options. So we'll just look at some of those options for you. So continuing pregnancy and keeping the baby, adoption and fostering considerations, or termination of pregnancy, and we now have the option within that of medical or surgical procedure. So for a young woman who chooses to continue with an unintended pregnancy or a planned pregnancy, good antenatal care and support is paramount. Continuing a pregnancy may well be done so with a view to adopting the baby once safely born. This might be a choice the young woman may not have considered, and this one may need exploring with an appropriately trained health professional and support person. And again, this is where there's the decision support tool, which has been developed by APNA. It comes in really handy because it does give you a guide for where to from here. And you can see up on your screen, you know, that there is that aspect of the tool that talks about the pregnancy algorithm. So looking at, you know, what her options might be, giving her information about each of those options and providing the appropriate referrals about where she might go for further assistance. So the tool may assist primary healthcare nurses in supporting women through choices, including preconception care for those planning a pregnancy. So for continuing a pregnancy, relationship building is imperative, and I mean, I guess I'm fortunate working in a metropolitan or outer metropolitan service that we do have young parent clinics up at our in our antenatal and gynae clinics, and they provide lots of support for young women who are continuing their pregnancy. So pregnant young women and their partners may look to the primary healthcare team as well for support and advice, as well as good holistic healthcare. And this is where our non-judgmental, frameworks will come in as well. Advice initially may well be simply to look at lifestyle choices that have the potential to affect the unborn child and provide advice regarding basically what we've talked a little bit about tonight, which is smoking and illicit drug use cessation, alcohol cessation, dietary issues or concerns, iodine and folic acid supplements, general health assessments including screening for STIs and advising on antenatal care options. Antenatal care, consider sourcing a program, for example at a local hospital which I talked about, that has targeted antenatal or postnatal programs for young parents. I think that peer support's really important. I think peer support for young people particularly is incredibly important, but in a real time of stress such as pregnancy, I think there's, it really does make a difference.
And there's lots of evidence to, there's actually lots of evidence to support that too, that's saying that peer support programs are really beneficial to mums and dads, both in the antenatal and the postnatal period. So it's so valuable, that service, to actually link them into the correct services as early as possible.
Absolutely. And I also think that, mental health assessments are really important in this pregnancy time frame, regardless of whether the young woman is wanting to continue the pregnancy or to terminate the pregnancy, because the outcomes are certainly much more positive if she can be supported through those choices and to vent any issues that she might have. And supportive peers and family if appropriate. I mean, you do get young women who come in and say that I'm homeless because my parents don't agree with me getting pregnant, and so some young women do have a lot of issues with their family of origin. So moving on to termination of pregnancy. So there are now two options. And they are medical and surgical, but I'll go on to talk about the surgical procedure because it's been around for an awful long time. And both procedures are very safe. The main risk really is infection. Women will sometimes say, well, is having a termination going to put me at risk for not being able to get pregnant in the future? And there's certainly no evidence for that. And often what I might say to a young person or any woman again who finds herself with an unplanned pregnancy is, you're fertile, you've been able to achieve this pregnancy. So, and that often helps them to sort of feel a lot better about decision making. And one of the questions that I will always ask people when I'm looking at decision making is what is the best choice you can make at this point in your life? And whether that's termination or continuing the pregnancy, it's important, I think, to weigh it up. Children by Choice also have some really good worksheets that you can work through with your clients around making some decisions and thinking about goals for future, such as how am I going to be in the next 5 years? What are my goals? What's my relationship like? So looking at all of those things so that they're making an informed choice. So with a surgical procedure, it involves the removal of the lining and the contents of the uterus through the insertion of a suction catheter to the inside of the uterus. The procedure is generally performed under light IV sedation, or often known as twilight anaesthetic. Very few clinics do general anaesthetic, but it is an option in some clinics. The procedure takes approximately 5 to 10 minutes, and then the woman will remain in recovery for about an hour under supervision and discharged home once able. Termination of pregnancy services are usually freestanding. They're not usually located in hospitals, but they provide contraception advice on discharge, antibiotics as a preventative for infection, as well as follow-up advice, including recommendations to have a post-termination checkup with a GP or a women's health nurse, even primary health nurse if that's the training that you've had. And that happens in about 2 weeks after the termination. I guess from my experience, many years ago, I used to do a lot of post-termination checks, but I think now what we find is women don't tend to turn up. They're well, they don't feel that they really need to have that checkup. And it's a shame because it actually is a chance to talk about how they felt about having the termination, whether there were any problems, and to reinforce any sort of contraception. So, for example, offer a LARC if it wasn't looked at in the past, and maybe talk about other options that are available. The financial costs of abortion may vary, so it's important to contact the clinics for accurate costs, especially after 11 weeks as prices can increase steeply. And abortion procedures are covered in some form by Medicare, but each clinic is different. And each state or jurisdiction, actually, there's different laws across Australia, which I think is quite a difficult concept as well. In New South Wales, termination is lawful to 20 weeks. And then if we go into medical abortion, so it provides an alternative to the surgical method. I see a lot of women who don't want to have surgical procedures. They might rather have medical. They don't want to be on a bed sort of feeling disempowered. Consider that, 1 in 4 women in their life has been abused as children, that it might bring back flashbacks of them sort of being, being on a bed having a surgical procedure may sort of create those flashbacks. So they're some of the reasons why they may choose to have a medical procedure, because they can actually empower themselves to be able to really, work with their bodies, and they usually have the tablets at the clinic and injection, and then they go home and have the abortion at home. Fatigue set in. Medical abortion is generally performed under 9 weeks gestation, whereas surgical terminations can be performed up to a later age, gestational age. Medical abortions are initiated within approved clinics with doctors that have been granted specific rights to prescribe the required medication, and this has been done through the Therapeutic Goods Administration. They're usually followed up in the clinic itself about 2 weeks after they were first seen, to make sure that there's no pregnancy. And by the way, the cost is the same as for a surgical procedure at the present time. And there is consideration of, looking at getting GPs trained up to do the medical procedure, but it really hasn't taken off in Australia, and I think the reason being is more about medical indemnity insurance than probably anything else. Would you agree, Ruth?
Absolutely, and this system, the medical system, has been used for a long time in France, and it's just we're just a little bit slower in Australia to take off. So it's a shame that hopefully it's going to become a little bit more accessible for women to actually use this service, to actually give them some choice in the matter too. So if there's any, we've answered quite a few questions as we've gone along, and apologies if we haven't answered your question, but we probably are getting to the end of the presentation. And if there's any pressing questions, we can probably do some emails or get back to people. What do you think, Ruth? Yeah, absolutely. And we're going to provide some links to the links that we've already established, but also other people have contributed some links. So thank you for that. And APNA will be sorting that out soon.
So back to Lisa.
Yeah, so I'd really like to thank both of you, and I'd really love to thank even more our participants, because they've been absolutely fabulous with their chat and providing us with a bit of input and resources. Just to let you all know that we will be sending out an email with the link, and we will be providing all the resources, the email links that the girls have talked about tonight. If you would like a hard copy, I'll send a link to the decision support tool, but if you would like a hard copy, I will need you to email me your name and mailing address, but otherwise the link is fine. So just a reminder of that. You can do that when I send the link to the recording, and then do a return email to me and give me your name and address and mailing address, and that'll be fine. Once again, thank you all so much. I really appreciate you. We started at 7:30 to try and allow our Western Australian colleagues to try and get on and not be rushing home at before 5 p.m. to listen. So I really appreciate you all staying on, and thank you very much. Good night.
Thank you. Good night.